Good afternoon, everyone. My name is Ariel Santos. I'm the Texas Tech Telemedicine Director and PI for TexLa TRC, or Telehealth Resource Center. We are very fortunate today to have one of my colleague and fellow co-member of the WMC Telehealth Advisory Committee. She is a pioneer and advocate for telehealth, her name is Dr. Hayden. She will be talking in a minute and will be formally introduced by Dr. Kendall. Joining me here today is our Project Echo Coordinator, Laura Roval, Max, who is our IT, also our member of our student interest group, Paige Livingston, Andrea Whites, who is a resident here at emergency medicine resident here at Texas Tech, and the senior clerkship director, Brian Kendall. Paige.
So this educational activity is a project of TexLA Telehealth Resource Center, a federally funded program with F. Marie Hall Rural and Community Health at TTUHSC, as well as Well Ahead Louisiana, with generous support from Health Resources and Services Administration, or HRSA. So we have some housekeeping on the next slide, which is requirements for CME credits for Zoom participation for students. So please make sure to keep your microphone muted, and you have the option of changing your screen while clicking on view. And if we don't know who you are, we can't give you credit. So please be sure that your full name is listed on the participant list, and to rename yourself if necessary. And you can also list the names and credentials of yourself on your email address. So please make sure that you take a moment to do that so that you can get credit for participating in this meeting. So these are some helpful tips on our next slide for participating in this webinar. So if we can advance the slide one more, please. Oh, maybe not. Okay, I guess go back. So make sure all of your microphones are muted, and keep your name in the list as listed.
And Dr. Kendall will now formally introduce Dr. Hayden.
Feel very honored to be able to introduce to you Dr. Emily M. Hayden. She's the Director of Telehealth and Associate Director of the Virtual Observation Unit in the Department of Emergency Medicine at Massachusetts General Hospital. Dr. Hayden is the founding chair of the SAEM Telehealth Interest Group, chair of the SAEM 2020 Consensus Conference on Telehealth and Emergency Medicine, chair of the Education Subcommittee on the recent ACEP Telehealth Task Force, and the chair-elect of both the ACEP Emergency Telehealth Section and the ACEP Health Innovations Technology Committee. She is a member of the American Association of Medical Colleges Telehealth Advisory Committee that developed the AAMC Telehealth Competencies. She is the course director for a self-paced online interprofessional telehealth course, Telehealth Foundations, Applications Across the Professions. Dr. Hayden's research focuses on telehealth and emergency medicine, from the use of telehealth nationally for transfer coordination to the comparison of telehealth to in-person physical examinations. Prior to her work in telehealth, Dr. Hayden spent a decade in healthcare simulation and developed the telesimulation program at MGH Learning Laboratory at Massachusetts General Hospital. Thank you very much for joining us today, Dr. Hayden.
Awesome, thank you. And yes, American College of Emergency Physicians was this past weekend, so now I'm chair of both the Health Innovations Technology Committee and the Emergency Medicine Telehealth Section. So here we go. I'm going to rule the world, right? No,
Right.
but no, I appreciate that. And one of my passions, as evident by my hobbies, as you had mentioned there, was that really thinking that telehealth will be transforming the specialty of emergency medicine, amongst other things, and that specialty of emergency medicine is also going to be shaping some of telehealth too. And so I'm sort of fearlessly and boldly at times, and maybe sometimes annoyingly to others, trying to really help our specialty see this, my colleagues in emergency medicine, as well as our hospitals and healthcare system, right? Because we're so we're sort of defined by the box of emergency medicine, and that we're defined by, well, we are in the emergency department, and whoever comes through our sliding glass doors are who we take care of. And now with the technologies available with telehealth and digital health, sort of we're in an identity crisis, right? What are we, right? If we're not just going to be defined by the box where we work. So really excited to be here today. I really appreciate the invite to come to speak, and hopefully there's some things here that are new. Maybe actually if what I've been trying to do to sort of educate and trying to make sure other people understand what emergency medicine is doing in telehealth. Hopefully this is all just so boring and you've already heard it, but I have a feeling that there's several things in here you may not realize that emergency medicine is doing in the telehealth space. So I'm going to take 1 second here to share my screen for my slides. So bear with me for a moment here. The slides rolling, rolling. Here we go. All right, so I've been at Mass General 16 years practicing emergency medicine. At that time, I had originally trained in Indiana, so I'm a Hoosier by heart, and then came out to do actually a medical simulation fellowship, and then transitioned to telehealth back in 2016. So we're going to speak today again about telehealth and emergency medicine and what's currently going on, as well as what I envision in the future for our telehealth and our specialty. So no conflicts of interest. So starting right here, so emergency medicine is relatively a younger specialty compared to some of the other ones, such as medicine, such as surgery and so on. We are now at 54 years. So this here was written in 2018. So it was year 2068. And this is the next 50 years of emergency medicine. So 2068 would be 100 years since the specialty was officially started. And this was written by residents who were the leads of the Emergency Medicine Residents Association. And they really looked as almost like a sci-fi, looking ahead to say, well, what is it going to look like? What are we in emergency medicine? And how are we going to be defined? How are people going to speak about us, talk about us, collaborate with us, and so on? And so some of the things they were saying was the value of emergency medicine physicians is that, diagnosticians, the availabilists, right? This is the specialty that has said that we will be 24/7. The resuscitationists, so for sepsis, for trauma, for stroke, the sort of that starting resuscitation piece until we can get them to the right area, which is also that next piece, dispositionists, right? You have a patient, they are in need for something. How can you help them figure out that this can wait for a few days to follow up in an outpatient clinic? This needs to go straight to the surgical team for them to decide OR or not. And so of honing that from basically, really triaging a patient once we're able to get some more data from the patient. And then the idea of the humanist, that from the emergency medicine side, one of the things that struck me when I was in medical school and had made a decision to go to emergency medicine was that piece that there's a lot of patients that come through the emergency department that are not able, for whatever reason, for maybe sometimes mental health or substance use or socioeconomic situations, that they're not able to follow through with other pathways that are built in the healthcare system. And so we see this in our we see these patients and see some things that just, it really is heart-wrenching sometimes of what we do take care of. And so this is the piece, these 5 sort of definitions or buckets is what the residents who are going to be our physicians the next 50 years, this is what they saw as our value. So, okay, so we have this value. So what does this really mean? So now we have this new black bag, right? Like we have the tools of telehealth. I'm sure that everybody here at least knows some about telehealth, that we've got video, we've got the asynchronous, we've got text-based with mHealth, we have remote patient monitoring. So these things are now able to have us go and take that sort of proverbial black bag back to a patient's home and care for them in a space that's not in our sterile or relatively sterile emergency department, right? We're able to go to where the patient is. And so we have this values of emergency medicine. We have this new technology. Where are we going with this? What's going to happen? And so I don't think anybody here was lost the past 2 years. We went through COVID. We're still dealing with some of that COVID, but this was the beginning of COVID. This was all within the first few months. Some of the articles coming out from both New York Times, Wall Street Journal, as well as New England Journal of Medicine, and really just, hey, everybody, telehealth is here. Like, wow, we can actually use this. And I'd already been in the space of telehealth for a couple of years. I'm like, really, now it's a great idea. But not that I wanted a pandemic to push this forward, but it did. It gave a lot of people who had not chosen one and had not wanted to, or was not sure if they could do telehealth, pretty much everybody was forced to do some type of telehealth to be able to provide some type of care to our patients during especially these first surge or two in COVID. And so we all of a sudden had a sort of force down our throats telehealth, right? And then looking back, telehealth in all specialty really increased. And so this was a systematic review of one of our chief residents last year had looked back to see, just even in the literature, this was August of 2020, what all had we done since then from 2019 on of what was happening in emergency medicine with telehealth. And then came to, is this again back to the available list. This was Judd Hollander, for those who may not be in emergency medicine on this. He is a emergency medicine physician and researcher who's been past president of our societies and very much into telehealth, and that he had put this into New England Journal about this idea of that we don't have to be defined by the box of our emergency department, that we're available at all times. And now with telehealth, we can be available for acute unscheduled care, even if that patient doesn't come through our doors. So how I'm going to speak about sort of the current and allude to some of the future states is going to be the buckets of before the emergency department visit, within the emergency department, after the emergency department, and sort of this new piece, which really wasn't something that emergency medicine would say they're part of, but a care continuum. Like, we really are very much episodic, but how might we be a little bit more in, especially in the value-based care world, a little more part of that care continuum? So here I'm going to go ahead and go through a couple of examples. These are not exhaustive, but these are examples of how we are using telehealth and emergency medicine that may be a little bit different than used in teleneurology, telestroke, telerehab, and so on. So for the before the emergency department. So these are a couple of programs around the country. This one I have on here is from Northwell in New York City area. And so they have the emergency medicine on demand. And so what does this mean? A patient who may be figuring out if they need to go to the emergency department or not, or they might want to call as if it was maybe like a virtual urgent care. They call and the video call is answered by a paramedic. The paramedic makes a decision right away, or not right away. They'll make a decision. Does this patient actually need a 911 activation? Do they need to come in? And they can go ahead and work on dispatch and do that. If they think, and this patient meets the criteria, that this patient may be able to be cared for over video, they then can transfer that call and transfer it to one of the emergency medicine physicians to go ahead and do a video call with them. And similar to the other virtual urgent care programs you may have heard of, then they can be seen by that. But the fact that we have a paramedic who's actually doing the dispatch for this, and the patients can call in, and that they can be diverted to not have to come into the emergency department, this is definitely newer on the scene for emergency medicine. There's a couple other different types of this, but this is one of the versions. Another one here is our using what we call mobile integrated health. And so some may be familiar with it. If you're not, what this includes is that mobile integrated health uses community paramedicine, which is specially trained paramedics, so increased scope of practice, paramedics that go out, and they also have some type of device, a tablet, a laptop with usually a hotspot, where they can go out and see patients. And so if you think of paramedicine or paramedics, prior to this mobile integrated health, most of the time paramedics were transport only, right? So that if you had a patient that was seen by paramedics, what they would do is do any stabilization that was needed at that moment, and then, you know, scoop and run, and that they would basically transport the patient in. The ability for a paramedic to treat and leave in place and let the patient not have to be transported in is being much more coming on the scene, especially with Mike Gonzalez there in Houston with the Houston Fire, and then the CMS ET3 Emergency Triage Treatment and Transport Act. There are more of these programs happening out there. That's a long story to go to what we've been using it for in our department since April of 2021 is, and actually January 2021 for COVID, but then expanding the scope, is that we have this set up in our emergency department in our hospital that if there's a patient where an ambulatory provider, so our heart failure team, primary care, any of the other ambulatory providers have a patient that they think may need to go to the emergency department, or they're unsure if they need to go there, but they may be able to stay at home if we're able to get out there, assess them, set of vital signs, and do some other potentially point of care labs, and maybe start antibiotics, maybe give some IV diuretics. We have a sort of list of what we can do with our paramedics and with our emergency medicine physician doing a video visit with the paramedic and patient's family and so on, where these patients may not have to come into the ED. If they're septic, if they are, low blood pressure, they look like they're altered mental status. Now, these aren't the patients we're trying to catch, but there's a whole subset of patients that we could go out, including patients that we wouldn't typically say need to come to the emergency department, but their goals of care are not to be transported. So we tend to have, for this program, we've had over 100-year-old patients. We have a lot of 90 and 80-year-old patients on this program too. So this is before the emergency department. And just like the one I just spoke about at Northwell Health, this is a patient, this is a program that helps deflect patients from having to come into the emergency department. And I'm going to assume there, you can give a thumbs up in the room there with the emergency medicine, but I can assume there that the emergency departments are quite crowded, just like they are everywhere else right now with our boarding crisis and everything. And so this is one more program that we're trying to pull another lever to help get patients care they need and maybe not have them sit and wait for 7 hours for them to be even seen initially in the emergency department. So this is another one. So mobile integrated health, we had our mobile response program. I'm going to come back to touch on this one again with the discussion of the post-ED also. So now I'm going to give a couple of examples of how telehealth and emergency medicine within the emergency department is happening. So this one is one where teletriage, I'm not sure, to be honest, I don't know exactly what you guys have been doing there at Texas Tech and emergency departments there, but teletriage is one that I think has been happening a little bit more diffused around the country now, not everywhere definitely, but if you're going to sort of ask people, this is one that they've sometimes been considering too. And what this is what it says, teletriage. Really what it is that we have someone who's remote from the emergency department, and they are able to connect in by a tablet, like an iPad or some other tablet, to be able to do two-way video with a patient. And so these typically are iPads that are in the triage area with the triage nurses. Sometimes there's ones where they actually are live all the time by the ambulance area, and then the person who's doing this, typically an APP, would be listening in to the medics giving the report out to the triage nurse there. And then they can go ahead and start basically a medical screening exam, be able to do a quick note to get things started, as well as putting orders in to get things started. So it's just bringing the triage, but bringing the treatment and care a little bit sooner, especially with our overcrowded emergency departments. And one of the things on this one is that it leverages the ability to have a remote provider, which allows you to be able to staff multiple emergency departments like this. So just having one for one emergency department doesn't always work out financially and sort of clinically, but if you have a couple of emergency departments in a system, this allows people to sort of flex to where it's a little bit busier and they can go ahead and do care initiation. And sometimes there's some programs that they can do treat and release. So for some very low acuity patients that may be waiting for that COVID swab, and that's all they needed, or a work note or something else like that, they could go ahead and catch that patient in triage, and they never need to go back and take up any of the space, any of the nursing time back in the rest of the emergency department. The benefits of this too, decrease the left without being seen because you're getting the medical screening exam in quite early in the process, as well as decreasing the door to provider time. So for some of these metrics that emergency departments are measured on and publicly available measures, this is one of the things that can be helpful for some of this too. Another example is this one that is located out of South Dakota. And so this is Avel eCare, formerly known as Avera. And so this is a very in-depth program. And so their program that they focus on is on critical access hospital and rural hospitals. And they have a system that's similar to some other programs too, but this is the one that I have the nice photos of right now. So that's what I have. But they, when they have subscriptions or contracts with the critical access hospitals, they will retrofit the hospitals with this help button. And so whenever there's a patient that may come in, maybe a trauma patient, maybe a stroke patient, what may be about a patient who is a pediatric patient and the provider that's on that critical access hospital day is not as comfortable with pediatrics, they can press this button. And within several seconds, I think they say it's 15 or 20 seconds, either emergency medicine physician or emergency medicine nurse will be able to come on two-way video. And that they can go ahead and help if there's a question, a clinical question. They even have this set up where their intubation video, the video laryngoscope, actually can also be seen by the nurse and physician at the control center here. And so if there's any question of airway issues, they can be there and help guide the provider through that, and so on. And so this is very much as as they say, like, let's try to keep these smaller hospitals open. We can't just transfer everybody out. These hospitals need to stay open too. This is a huge employer for these smaller towns. And so supporting these patients, they may not need to be transferred, and or if they need to be transferred, helping with that care initiation, helping with that resuscitation earlier. And so this is another program that's within emergency departments, very similar to the telestroke services, where you sort of have that video and it's someone that's able to give some extra care advice to the patient in front of you. So provider to provider, and help with either care initiation before transfer or to maybe keep the patient there. So those are the two that I was going to speak to that are within the emergency department. I'm now going to go ahead and talk about both the post-emergency department and care continuum, because I feel like some of those sort of starting to feed off of each other a little bit. Keep an eye on time here. Good. Sorry, I'm a fast speaker, so I'll try to slow down a bit. One of the ways when I moved out of the Midwest, I felt like I was a little bit more comfortable in the East because I could speak fast and not have people yell at me as much. They still do. So, so for the post-emergency department, so the remote patient monitoring. So many of us are familiar with remote patient monitoring. There's multiple different types of this. Some specialties have taken this on, especially on the heart failure side, with quite a bit of different and actually quite complicated remote patient monitoring. But then what I have here is just even the part of having the pulse oximeters, where before COVID, not many people would have had pulse oximeters at home in the general population. COVID happened, and now many people have them at home, right? So there were programs that started up during COVID where emergency medicine, who was really never into the remote patient monitoring scene at all, they were actually setting up programs to send patients home that typically they probably wouldn't have sent home during some of our surges, but there was no room in the inn, right? There was no room in the hospital. And they're like, well, we think you're going to be okay, but here, let's go ahead and give you this pulse oximeter. We'll have someone check in on you. And the programs were different after that, right? Like some programs, emergency medicine would follow up. Some there would be coordination with the primary care services, critical care services. And there actually were some companies that would go ahead and say, look, we'll go ahead and do the whole thing for you. If you send them home, we'll work with you guys. We'll go ahead and we'll give them the device. We'll be the ones monitoring it. We'll be the ones responding to the escalations in care and so on. So remote patient monitoring came on scene more for emergency medicine during COVID. I think that emergency medicine should be keeping an eye on the remote patient monitoring space for two reasons. One is that we're already seeing it also with wearables, right? Where in the emergency department, someone's like, hey, my Apple Watch said I was an AFib. You're like, okay, now we got to go through this and try to figure this out, right? There's also patients that are part of remote patient monitoring programs throughout your healthcare system, and they may show up on your doorstep. And it may not be what they were told to do, but they somehow came in, and now you have a device that has data that you may not even be sure what this data is actually means. And so it's this idea we should be more aware of the remote patient monitoring systems for the patients that you may be seeing. The other part about remote patient monitoring is that I will bet that if you go to any of the remote patient monitoring programs, there probably is on 85, 95, 99% of them that somewhere on the care algorithm says, call 911 or go to the emergency department, right? Like it's not going to be the first thing on there, right? Like there's going to be like, call the nurse practitioner for the heart failure team or call this number, but somewhere on there's going to be the emergency medicine piece there. And if we start thinking about the systems that have many remote patient monitoring programs, they're going to be so much extra work to have all these different people trying to monitor for the care escalations. So is this a space where emergency medicine may become a little bit more involved in some of these systems, because we can maybe virtually be able to be that person because we're availabilists, we're 24/7. Could we help respond to those and maybe deflect that patient from having to physically come into the emergency department? So remote patient monitoring, I think, will become a little bit, not a little bit, more and more a part of some of the things that emergency medicine will be working sometimes directly with. And then the other example is our newest program that we've been running at Mass General Emergency Department. And I have not really come across many others like this yet, but I do think this is a space that warrants us as a specialty to really keep an eye on and think more about. And so this is this idea of the virtual observation unit. I'm not familiar there. I don't know. I can see the Dr. Santos and team over there. Do you guys, thumbs up, do you guys have home hospital at home there at Texas Tech? No. So home hospital, for those who may not be aware, is the ability or basically a program that enables patients who are inpatient level of care, rather than being in a hospital bed in the hospital, they are at home, and they're at home with different adjuncts, remote telemetry, iPads given to them with hotspots to be able to do video visits, care team members that come in, whether it be for the hospital home physician, APPs, nurses. And so this is happening more and more, especially with our crowding issues, that it's sort of hard to build a new hospital or to be able to expand more beds, but people have their homes, right? And that you could now take out, especially with the tools of telehealth and also with the other care, at home care that we've already been doing for years, but now pulling it together to an inpatient level of care, it's happening more and more. And we've had this at our hospital at Mass General, as well as our sister brother hospital, I don't know how we would actually say this, but Brigham and Women's Hospital, part of our healthcare system, they both have had hospital at home programs. And so from our emergency department, we have developed a virtual observation unit, which is similar. And so this is patients who typically would be in our ED observation unit. So they're not fully inpatient, but they're not ready to be discharged right away from the ED. So it's usually 23 hours to 48 hours of maybe a little bit more of IV antibiotics, see if that cellulitis recedes, and they can go then on oral antibiotics. Gastroenteritis, they're just not ready to go home and start really taking enough fluids yet. All these things that we would have in our observation unit, well, we can take a subset of these patients to the home now. And so effectively, we've expanded our observation unit by 10 beds without having to ask the hospital to say, hey, can we have another inpatient floor? Because it's easy, right? Can you just give us another inpatient floor that we can turn into our observation unit? Or having to like knock down walls and build other things. Like we just have now leveraged the ability to have and what we use ours is the community paramedicine, that mobile integrated health, and to be able to have the remote patient monitoring. And so this does use telehealth. It uses multiple modalities of it. So for my telehealth heart, it's like be still a beating heart. I love it. That we're using multiple different modalities of this to be able to help these patients be cared for in their homes. And so the telehealth side, we're doing video visits. So for our virtual observation unit, we do not have, like the inpatient unit does, we do not have our physicians or APPs or nurses go out to the home. We have our community paramedic. And then when it's time for a visit, the patient can have up to 2 visits a day from the paramedics. When it's time for the visit, after the paramedics have done their initial evaluation, obtained vital signs, which especially for emergency medicine, to do a video visit without vital signs is very uncomfortable for many of my colleagues. So we have that set of vital signs. It's time for the visit. So the medic will go ahead and message us and say, we're ready, we'll come on. And so it'll be the virtual observation nurse. It'll be the case manager also that works with us that's available. It'll be the physician, the attending physician who's on from emergency medicine, and they will be able to be there in the patient's home with the paramedic, including the patient's caregivers that are there, whether it be maybe their personal care assistant or their health aide, as well as their family members. And so we have the video base for that. We use remote patient monitoring so that the times when the paramedic isn't there, they have a tech bag that has the remote patient monitored equipment in there. The nurses will call when it's time for vital signs. So every 6 hours, they're calling the patient, they're doing a video call with them, they're checking in, they're documenting whatever medications they took since the last time, they're checking their vital signs and making sure that it's still safe to be at home. And then the other piece is the asynchronous, is that there's more like our messaging between providers are all asynchronous texts. We basically are using MS Teams because that's what our healthcare system had available. So we're using that for our video. We're using that for our communication amongst all the team members. So this virtual observation, which is really taking that hospital at home model and bring it to the emergency department. This also helps with the patients that if we are now at 48 hours and they're still not getting better, we just work with our home hospital team. We're all in the same group. We can go ahead and then transition them over, and then they would take over the inpatient care while the patient's still at home. And I still remember Ativ Malhotra, who's health services researcher at Harvard School of Public Health, internal medicine. He had written, it was right before, it either came out right in the beginning of the first surge of COVID or right before that, where he had put an opinion piece out about how we're really trying to decrease the home to home time and trying to decrease that time. So it's not that you get into the hospital a few weeks, then rehab, then so on and so on. How can we decrease it? And really what I'm trying to get to is that how are we able to not even have to have some of these patients come into the emergency department and take that home to home time to 0, right? A patient who may have pneumonia that may need IV antibiotics, or a patient with heart failure who has now some volume overload. How can we maybe spare them from having to come into an overcrowded emergency department? How can we go to the home, do diagnostics, start treatment, and if they need to be admitted, be able to just have them be admitted and stay there in home and be discharged to their home? I recognize it's not for all patients, but it's for more patients than what we would realize when we start realizing what telehealth, what other structures such as this hospital at home sort of scaffolding puts out there for patients. So virtual observation unit, and I then spoke about the remote patient monitoring, are the two sort of examples I have for post-ED care, as well as part of this care continuum now. All right, keeping an eye on time now. So just going back again, because I did mention this earlier, and these are things that are much more new on the scene for emergency medicine. So just so it's clear, I mentioned in the beginning when it was the pre-ED, was the mobile response program. So this is for patients that have ambulatory care providers who think that a patient may need to be seen. Our emergency medicine attendings will review that case with the PCP in the chart or with the heart failure team or whoever's the ambulatory provider that sends this in and decides like, yes, we should, or no, this, like, unfortunately, with the resources we have available is probably this patient's exceeding that. We will then, if we accept, we'll go ahead and do the visit with the paramedic, and then the patient can remain at home. We may say, you know what, your sodium's 121. We really need you to come into the emergency department. Like we did our point of care testing. There's stuff that we just can't do here at home safely still. And then we could also maybe admit to home hospital. Our virtual observation uses very similar platform. It's just we have our virtual obs nurse as well as case manager, as well as the tech bag. And so these are patients that were in the emergency department or in our observation unit, and we're deemed to be able to continue their observation care while at home. And so they're accepted again by the emergency medicine attending as well as the virtual obs nurse. They'll have the visit by the paramedics. They'll have the check-ins for the nurses for some of that remote patient monitoring. And then they can remain at home in obs. They can be discharged. We might say, again, like, you know what, you need to come in. We don't have availability to do X imaging study. We'll need to bring you in. And then also we can admit them to our home hospital. So this sort of telehealth piece that prior to the pandemic and then during the pandemic, and I say during because I know it's not completely over yet, but like during those first surges of the pandemic, telehealth really was sort of an either or, right? It was in parallel. It's either you're doing in person or you're doing telehealth. I think because of what all of the people who had to do telehealth, whether they liked it or not during COVID, I think enough people, whether it be clinicians or administrators or patients, right? They realized that, well, why don't we, like, it's almost like a recipe. Let's take a dash of like remote patient monitoring here and a pinch of maybe some video-based care here, and have now integrated into different care pathways. And that's what I think this is a great example of, is that we have different pathways that if we didn't have the community paramedics, that this wouldn't work. If we didn't have the telehealth, this wouldn't work. If we didn't have some of the other home-based care infrastructure, it'd be really hard to do. But now when we have all of these things, we're seeing what the future of some of our services, our programs are going to be like. It's been a fascinating ride on these things because we are taking ourselves outside of that box of the emergency department. And I don't know, almost every day or every other day, we're having a conversation saying, is this the scope of emergency medicine practice? Is this more of primary care? Like, where should we be in this space? And these are questions that are going to continue for a while because we've been so defined by our box of the emergency department that coming out of it is going to make us have to keep looking in the mirror and saying, what does the healthcare system need from us? What are we thinking that we're of value to be able to provide? And I think you're going to see this more and more happening over the next few years of what we're going to be doing here. So shifting just quickly to a little bit, this is not shocker to anybody doing telehealth, but the barriers are similar for emergency medicine, just as it is for other telehealth, such as our licensure requirements, our credentialing requirements. So this program that we would love to do, our virtual observation unit, love to do that in our nursing homes, right? We have so many geriatric patients that we're seeing and able to help them stay at home. However, for us to start going into the nursing homes, we'd have to credential all of our physicians and all of our providers at that each of those facilities. And it's just administratively too much for us right now. The technology, I could rattle off, it probably is all the fingers on one hand or all the different types of technology that we're using to take care of these patients. Really frustrating, right? I'd love to have it all integrated into one EHR that I'm not bouncing around and having to cut and paste the EKG from Zoll that we have sent to us that I have to basically cut and paste and then put into our medical record. So we have, and actually now that I say Zoll, maybe six different technology to do one program. And so these are barriers. I'd rather have all of these than not have any of them, but it is something that in the future be much nicer to have those much more seamless. The training, so the training is like a big piece, right? Training is not only training providers of how to turn on your camera, right? Or how to do X, Y, or Z. It's how to learn how to be in this new workflow and how to have this new paradigm of it's not just what you have available in the emergency department, but it's what you have available on the truck for the ambulance or what you have available to send patients to that may not be the emergency department. So it takes a different paradigm shift in the head of the physicians. It's also that we need to make sure that our trainees are getting the actual exposure to and the awareness of these types of training models. And that's something that it's hard because these models are different. They're locally responsive, right? So they're different for where I am. And if another program is going to start up like this, it's going to be responding to the local needs of that hospital or healthcare system or that community. So training is still a tough one on this one. And then it's also that training of, it's almost like a reskilling of our physician workforce, because I don't want my colleagues to feel like, am I going to become irrelevant? Yet it also is a new skill to be able to provide this type of care. So how do we start thinking about the reskilling of our workforce? So many things on that one. I won't go any further on that. And then the reimbursement, right? Like, so some people who are listening to this be like, well, how are you getting paid for this? Like, is this actually going to be able to pay for itself? And there's a lot of uncertainty right now with reimbursement, right? Like, we are billing patients for this, but some of this is dependent on the waivers that have been available with the PHE. And when the pandemic health emergency goes away, this funding may go away 5 months afterwards, right? And so then we're going to have to decide otherwise, what do we do differently? So reimbursement is a barrier. I'm thankful that our healthcare system sort of took this risk to say, we understand that this billing opportunity may go away. However, we also feel like this is something we need to do, like we should be doing this. And so I feel grateful that our system had the resources to be able to turn towards this. Yet I know that everybody's sort of looking at whenever there's a new thing coming out from CMS is like, what's next? Like, are we going to be able to have this stay permanent or not?
Hey, Dr. Hayden, since we
Yeah.
are in the reimbursement, there's actually a question from Dr. George. How is the reimbursement structure for your, virtual observation unit?
Happy to
So
say,
how-
yeah. So
Yep.
what we're doing right now is that we are billing for observation care, and we're billing for Medicare patients because they do reimburse for observation level care from the emergency department. The other payers, we're only billing for the video visit. So this is a program that's, I'll say, it's heavily subsidized by our healthcare system and our hospital. And it was sort of a investment decision by our hospital and as well as our healthcare system, our population health management of the healthcare system to say, like, we're overcrowded, we need to do something else, and this is a way to do this. So the reimbursement, we are able to receive some reimbursement. However, it's not enough to be covering the cost right now. So I have to be honest about that one, that this is definitely an investment from the hospital, that it's a capacity creator, as well as hopefully a patient experience improvement that I didn't put it on here, but from the hospital at home side, that they've been able to show that patients who are actually treated at home versus in the hospital are more active, lengths of stay are less, costs are less, and so on. So reimbursement, it's a thorny issue. We do bill for stuff depending on which payer it is, and then we're hoping for a more favorable reimbursement environment going forward. So.
Kind of follow-up
right.
question
Yeah,
on that,
yeah.
Emily, because
Yes.
we're here, it just struck the right while it's still hot. So there's two questions regarding risk managers and the malpractice, because this is making some of, probably the ED position kind of leery about, well, I cannot see them and evaluate them properly. Could we do that, using the virtual platform, evaluation and risk management?
Yes. So, and thank you for doing this, because I have not been looking at the chat. So thank you for being able to be my chat translator. So in terms of risk management, we have a malpractice insurance company in risk management, and that they have signed off on our virtual care. We make sure that we check in with our general counsel whenever there's changes, because this is definitely newer out there. And for this virtual observation unit mobile response program, this is staffed by, it's an opt-in, It's not a requirement from all physicians. And so we also leverage, because it's remote work, we have physicians not only from the Mass General Emergency Department, we have physicians, the emergency medicine attendings from across our healthcare systems. We have, I think it's up to like 32 physicians right now, and they're from 4 different hospitals in our system. And so it's an opt-in, because I know that there are some of my colleagues that are concerned about the risk atmosphere on this one, and that we do tell them that, you know, we're not asking them to be cavalier cowboys. I shouldn't say that to the Texas crowd, I know, but to not be able to, not to feel like we're trying to put them on the spot. If there's a patient that they feel is not safe to be at home, that we are going to support them in if they're going to decline the request for us to go out to see them, or once we get there and we're not trying to unduly try to push them to say, well, yeah, they're really sick, but we could probably keep them at home, right? Like, we're trying to make sure they feel comfortable with that too. So I think that it's and this is why we have the attendings on this one, because we're still learning this environment. We don't have this where this is even though we're an academic department, you know, we don't all of a sudden have our residents doing this and we're just sort of in the background being like, yeah, it sounds like a good idea. Like, we have the attendings who have been experienced in emergency medicine that have a little bit more grizzle on them, right? That sort of says like, this doesn't sound good. Let's not have this patient stay at home. So that's a roundabout way to sort of say on the risk management. I think it's the pieces of it's opt-in for the physicians who want to do this, that we do not unduly tell them that and try to encourage them to keep patients against their moral fiber, right? That the patients who need to come in, they need to come in. And then we also have our malpractice insurance company who says that they will cover our care of telehealth here too. So awesome. All right, I'm gonna go along here speaking in my like 2 times speed. Just real briefly here too, it's sort of what's the evidence? Great question. And for anybody, I know there's a med student there and a resident there. If you want to get your scholarly activities in, there's lots of gaps in the knowledge on this one. So this one was referred to in my introduction that I chaired the 2020 consensus conference on telehealth and emergency medicine. And so we had these 5 buckets that we were looking at for this. So what are our gaps in educational needs and outcomes? What are our gaps in healthcare access, right? Like, we keep saying telehealth is going to increase access, but yet we also see can exacerbate access issues. The idea of quality and safety, how do we determine quality and safety? What is quality and safety out there? Research facilitation. So now that it's not just using telehealth for telehealth care, but how, especially in emergency medicine, when patients come in to try to enroll patients in clinical trials in emergency medicine, all of the requirements for consent, like this patient is sick, they're not gonna be able to consent right now. So to be able to start having some, using telehealth to be able to reach maybe other people, to maybe have the PI who's at home and the one patient that came in that may qualify for their clinical study, can they do this by telehealth and do it by video? So what are some of the other gaps in our knowledge of research facilitation using telehealth? And then our big one for our specialty is workforce. What does this mean to our workforce? So we looked at this, and the bottom line is lots of gaps, lots of opportunities for ability to look at this more and to try to figure out in all of these gaps of sort of where should we be going in emergency medicine and in telehealth in general. And so this one I have for at least the emergency medicine crowd. This is our Board of Emergency Medicine website. And I circled this piece here because it's this idea of transforming the specialty. And I do, like I said in the beginning, I do think that well, one, I think that our specialty is going in a little bit of an identity crisis right now. And 2, that I think telehealth is going to be transforming the specialty. And 3, like, I'm really trying to help do that too. So to try to help us thoughtfully use telehealth and trying to work telehealth thoughtfully, effectively, valuably into emergency medicine and emergency medicine care. Whew, all right, I threw a lot at you at a fast speed. So luckily it's recorded so you can slow it down if you really want to hear this stuff. But I want to open up because I know there's other questions, and I've not been looking at the chat. So if you want to translate, that'd be awesome.
Great. Well, that was a wonderful talk. So thank you very, very much. And don't forget to fill out the session evaluation survey during your CMEs. We'll open up the floor for questions.
I really appreciated your talk, Dr. Hayden. And as you were sitting there and talking, you know, there's so much angst in emergency medicine now with that workforce report, the workforce study that came out, the recent match issues that we had, and wondering, you know, are we still able to attract the medical students to our specialty? And as you're talking, it reminded me that there are so many opportunities within telehealth that emergency medicine, we are the perfect specialty to fill those gaps and be able to innovate the technologies that are needed to allow for further emergency style care through a telehealth environment. What in the next 10 years, where do you see the technology getting to a point where, you know, are we going to be able to have a more streamlined process? Are there things going on in the background right now that that you see coming down the pipeline?
Yeah, so I mean, the pain point of this lack of seamlessness is recognized. And so there's actually some companies out there that emergency medicine physicians have started that are looking at the how do you integrate these platforms. So there's a couple of ways, and this is one of the pain points that I with the Health Innovations Technology Committee. It's a very large committee of very seasoned expert informaticists. And so I'm like, we got to get this. And they're like, yeah, this is sort of how EHRs were before, where it was all these different things like patched together. So we're getting there. It's not stopping us from doing things, but I do think within the next 10 years, there will be more integration. When I would speak to the EHR vendors, we have some of the vendor reps are on our committee. And it's one of those things that they're like, yeah, like it makes sense. Like I tell them, like, look, it's like PowerPoint. Our EHR is like PowerPoint, where PowerPoint had changed the way people present it. Like, right, I just did slides too. I could have done a totally different presentation, but we sort of get into the bullet points and the different pieces on slides. EHRs are the same, right? So they sometimes are directing our care more than before we would have had this electronic health record. And when I'm like, if you're going to be doing that, like, I don't want you to keep swaying emergency medicine away from virtual care, because the way it's built, most of the virtual care is on an outpatient platform. Our emergency medicine platforms, depending on the vendor you have, usually it's an inpatient platform with outpatient or ambulatory pieces fit in, and it's this hybrid. And so it's very clunky to do virtual care. And I'm like, why can't we do more? Like, why can't you? Like, you are now directing us down a path that I don't want us to go.
Yes.
And one of the things they said too was like, well, yes, we get what you're saying. That's great. But you know what? The people that we're probably going to be changing more to are the ones paying the check, right? The ones paying the bills. And so those are not the emergency departments. Those are the ones that are the CIOs of the healthcare systems or the hospitals.
Yes.
And that may or may not be emergency medicine. And so they're like, you know, so we get it. Like, we get what you're saying, but we also have this list of what everybody wants changed on the EHR. And we're going to sway to whoever's going to be saying like, yeah, we'll go ahead and put the X number of billions, millions, whatever it is, to go ahead and change these. So I think for emergency medicine, we have a little bit of an uphill slog, yet I think that there's a little bit more momentum now than there was a couple of years ago. So
that's great. That's great.
Long answer.
Yeah, no, it's great. No, it's perfect.
Dr. Hayden, I really enjoy, you know, the talk. By the way, in the chat box, there are, you know, your references and everything, courtesy of, you know, our librarian. We have librarian
thank
in
you.
the house. So all your references are available to our audiences.
Great.
I enjoyed as well. And I'm looking in the future. I'm hoping that, you know, there are, you know, a lot of patients that could avail of, you know, the virtual observation unit, because they are really crowding the emergency room. I'm actually foreseeing that, you know, hopefully we could do more point of care testing. Like, you know, we could get their potassium level. So we have nephrologists there, you know, was thinking of probably, well, you know, they probably need a dialysis, and this could be even done in the dialysis center. And here in Texas, we have a lot of, you know, freestanding ER, and we have a lot of critical access hospital, rural critical access hospital, that hopefully sometimes we just need to advise them on what to do and kind of hold their hand virtually on helping manage the patient. So probably could get them out and do unnecessary transport. We're in a hub city, Dr. Hayden. So we have a lot of patients being flown in. And so there is a possibility to cut down on all those, you know, flown in and, you know, unnecessary transfers of patients. By the way, before I go, are there any metrics you're tracking?
What a great question. No, yes, right? Like no and yes. So it depends on what metrics. And so when I say great question, we have one of our fourth year residents is taken on, and he got an analyst publication last year. And we were so excited for him. He looking at at least quality metrics in emergency medicine telehealth. And what I'd mentioned a few slides ago, a few minutes ago, was the piece that most of these programs are grassroots and they're locally responsive. And so similarly, the metrics that are being measured are locally responsive, right? So like if this is something where there was a certain reason why they developed this program, this is going to be one of the metrics you're seeing. Like, was it a capacity issue? Okay, was it a length of stay issue? Whatever this was, that's one of the things we're going to be measuring. If it was because they had funding from a certain funder and that funder said we need to be doing that. So it's there's sort of the pie in the sky of what everybody wants to be measuring for metrics, such as decreased door to provider time, decreased antibiotic prescriptions for viral illnesses. It really depends on what the different barriers as well as motivators are. And this gets back into sometimes even the EHR. What can you actually gather from that data, and what's easy in the virtual space in emergency medicine, and what is it's just administratively so hard that like that's on the parking lot for when you can get more resources for that. So answer is yes, some places are doing these. It's not standardized, just like I went through all of these telehealth programs. They're not standardized. All these sort of points of light will hopefully sort of coalesce to be much more of a standardized at one point, but back to the gaps in knowledge, we don't know yet what's the best for us. So, or best for the system, best for the patient. So.
Dr. Hayden, I'll just like to read, a comment from Dr. Troutman, who's actually invited, early this morning. He said, great talk. Would love to connect with you offline. He lead the global medical response and innovative practice, and he is here in Lubbock. He provide in-home care for hospital at home in 8 states and several sites, and
Awesome.
have 83 and 63 sites across U.S. and nurse navigation, which diverts around 8,000. That's a lot. 911 calls per month.
Yeah.
To alternative care sites. So I will personally connect you with Dr.
Awesome.
Troutman.
Perfect. Yeah. And then my email is on there. And also if anybody, I'm happy to chat more. I mean, I could go on and on about this. My family gets sick of hearing about it. So if there's others who want to talk to, my family would actually be like, yeah, take her for a little bit, please. So happy to talk to anybody. So awesome.
Any other questions? Paige?
I have worked remotely for the past couple of years for a surgical group doing patient-reported outcomes, and I'm really excited to see this push into the clinical space. So really happy to have remote work as part of my future as a physician as well. Thank you for this. I've learned a lot.
Yeah, awesome. Well, great. Well,
hey, Emily,
yeah.
Dr. Hayden, I just like to ask, what kind of training are you giving? I know we work about competencies.
Oh, yes,
with
the good old
AAMC.
competencies.
Yes, but how about the training at MGH with your nurses, with your residents and physicians?
Yeah, so the training. So we are ramping up to be starting our more formal telehealth training, planning for starting in 2023. So this next upcoming year. And so right now it's elective. I do have a telehealth fellow working with us now.
Telehealth fellow.
Yeah, telehealth. Yeah, I know telehealth fellows, right?
You know what? I'm kind of thinking this may be a separate branch of, residency for emergency medicine, and it will be a different residency, telemedicine.
Yeah,
residency.
and most of the fellowships right now are to be sort of focusing on not just get you ready to do telehealth, but it's also ready to lead telehealth programs or telehealth change. So that's the fellowship. And then there's for the nurses, it's more of the nurses that have been chosen for the virtual observation unit, and not as much unfortunately for the rest of the nursing crew in the emergency department. They are doing with like video interpreters, but in terms of like the sort of nitty gritty of telehealth, unfortunately it's a gap for us. And so yes, so even though as part of the competencies, it's that that next step is a big leap to go to. How do you actually teach to those competencies and then assess the trainees on that. So we are doing a couple of things with standardized patients. We've done some pilots and we're working on some more where we have standardized patients who's on a Zoom, like boom, right there, you're in a telehealth visit right there. Like we could actually even do a telehealth visit. I can be a patient right now, right? And we could go ahead and do this and give feedback right away. And so, so more to come on that. And I'm probably similar for you guys in terms of that, but there's probably some things going out that you already have an interest group there, which is amazing for the students. And yeah, I think we'll be seeing much more over the next couple of years of what people are finding works well for the competencies. So.
Along that line, for those who are listening who think, you know what, I want to get into telehealth. This is something that really interests me. What advice do you have for them to say, okay, do this? What residency should they pursue? What should they plan on doing a fellowship? Is there certain mentors or other places where they can go to find that advice or to get guidance?
Yeah, so for the emergency medicine side, I think that this is going to be, so I think that the resources right now would be the AAMC has the competencies. There's a digital playbook from the AMA. So for even those outside of emergency medicine, this also would be a helpful just to get an idea of what's going on out there and what some of the barriers and motivators and so on. So I think that's a good sort of primer, however you say that. And then I think for residencies, I think it's hard because it's so dynamic, right? You go in to look for residencies and one program doesn't have anything, but yet the next year, all of a sudden, poof, they've got this virtual observation unit, right?
Yes, yeah.
So I think it's hard to say to go to that. And I also think that the trends are going to go that we're going to start seeing requirements from the ACGME and the residency review committees that there must be some type of telehealth training. And I think given that, I think there's also going to be more sort of, I don't want to say off the shelf, but things that are created that may not require that each residency has a telehealth program that's already running and has someone who's already facile or an expert in telehealth that you can leverage that there's other people. And so basically it's a module that may be a module that's created by one of the societies or another group. So.
Thank you.
Yeah.
By the way, you mentioned teletriage earlier on. 12 years ago in Toronto, I'm actually doing teletriage, telling them how to put chest tubes in rural areas and telling them to come in and no, you could keep the patient there. The burn is so small, it could be taken care of there. And there's a lot of huge savings doing so. And so and sometimes rather than the API that or gallbladder, rather than going to you guys, I already knew it's a gallbladder and appendicitis, probably go to the floor rather than bother you in the emergency room. I think there's so many utility. I'm putting that as a surgeon, as a telemedicine doc. But my question is though about AI or artificial intelligence. I'm kind of thinking, I'm mentioning, going to the ED rather than, talking to a triage nurse, I could just put in my symptoms in there and tell me, what are the tests you have to do before even seeing a doc.
Well, I think that, and I think that it doesn't even require you to even come into the ED, right? That like, I already, so we, this sort of internal waiting room where people are seen a little quicker, but they're not really in the emergency department, but they are. That was a response to the overcrowding. Now we have teletriage, which is a response to overcrowding where a patient who's physically in the ED can be seen by somebody remote to get things rolling. That next thing is going to be just like I had presented the Northwell Health one, where before a patient even comes in. And these programs are happening. There's also some of the EHRs have this built in. I think it's the On My Way function from Epic, and I forget the one that's maybe in Cerner, but that there's ways before people even come in where you're like, yeah, you don't need to come in, or wait, no, don't go to this hospital because you know what, they're not going to have what you need for this one. Why don't you drive a little further and you're going to go to this one because you're going to be transferred anyway. Like that stuff is going to be happening. I keep joking that like our triage next is going to be in our garage because people can go on the app in the garage and sort of start things out, right? And then at home, and then who knows where. So I think that AI is going to play a part of some of this. Once we have some machine learning, we have enough data to say, okay, these are the patients that did okay, and they can go home. But for that machine learning, you need to have enough test patients to be able to start having the machine, quote, learn who's the appropriate patient for X, Y, or Z. So
there's probably, two more questions, but do you have any resources for reimbursement? These things changes, by the way, as soon as we're talking, as we are talking right now, there's legislation being done regarding reimbursement. So
yes.
But
so the legislation,
resources?
So at least from the emergency medicine side, I'll point to one of our colleagues from ASAP has a regs and eggs. So I have backyard chickens, so it always is easy for me, the eggs. So so regs and eggs blog. And so I think if you Google that Jeff Davis keeps that up to date quite frequently. And then of course, also the telehealth resource centers, right? And the Center for Connected Care, Connected Health. I always say that wrong, but that, yes, those, I mean, there's a lot of resources out there that that really want to make sure people are up to date on what's going on there. And so I think those are the resources, telehealth resource centers, as well as specific to emergency medicine, the regs and eggs blog. And they have stuff that would come out for telehealth too, so.
All right. And John had a question, and we're going to share, some of the information to him as well, all the references that you have. He's asking if you've written a book, about this. So
I've written a book, not yet, but yeah, trying to, as I told Dr. Santos earlier, that I'm actually going to other specialties now, and I'm presenting to the surgeons about comparing in-person to video-based telehealth exams on people with abdominal pain. And the bottom line is that we didn't miss any, we didn't have any morbidity or mortality on 30-day follow-up for
great.
patients seen over video coming with abdominal pain to the emergency department. So,
Great.
not a book, but really trying to diffuse out there and start conversations and trying to better understand why or why not. And keep trying to work on the transformation. So
this is all wonderful. And Brian Norman in our engineering department is happy to help with, process flow and whatnot. So we have multiple disciplines and, in our audiences. By the way, before we go, next slide, please. We're going to present you a virtual challenge coin, Emily, but we're going to send this to you by mail.
Oh,
yep. So that's our challenge coin. Thank you very much for your service. Thank you very much for everything. And next slide. Next month, we have another webinar, and we met Dr. Chandra, right, in Boston. So there are two Center of Excellence in Telemedicine in United States, University of Mississippi and MUSC, South Carolina. So we will talk about building a telemedicine Center of Excellence, next month. So thank you very much, Dr. Hayden. Any final words, Dr. Kendall?
I really appreciate it, Dr. Hayden. Thank you so much. It was inspiring to hear, and I think all of us as emergency physicians and everyone else listening to this call gives us a good idea going forward of what we can do to start making use of this telehealth space.
Awesome. Well, thank you. And thank you for your time. And again, you can listen to it again on slower. If I was too fast, I apologize if I did. But yeah, no, really appreciate the time. Really look forward to seeing sort of what happens in your neck of the woods there with telehealth too. So
Thank you.
We'll give you an update next time we see each other.
sounds good. All right. San Diego in a few weeks.
Yes.
All right.
Thank
See
you.
everybody.
Bye-bye.
Take care now.